Hello everyone, it's my pleasure to present our work here in ISMB 2022. My name is Bowen and I'm a PhD student from MSCB, the Machine Learning and Computational Biology group of ETH Zurich. And the title of our work is Prediction of Recovery from Multiple Organ Dysfunction Syndrome in Pediatric Sepsis Patients. First of all, I would like to say thank you to all the collaborators. It is not possible to get this work done without their full support. And they are from 4 different institutes: ETH Zurich, University Hospital of Bern, and Robert H. Lurie Children's Hospital of Chicago, and University Children's Hospital of Zurich. So in this study, we have 2 main focuses. And the first one is pediatric sepsis. And I would like to give you a brief introduction of what is sepsis. Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. And sepsis may progress rapidly and lead to severe organ damage and death. On the right-hand side, you can see a fact sheet of sepsis. It is from the World Sepsis Day event, and there are about 50 million sepsis cases each year, and it causes at least 11 million deaths. And for every 5 deaths worldwide, 1 of them is associated with sepsis. And sepsis is also the #1 cause of death in hospital, the #1 cause for hospital readmission, and also the #1 healthcare cost. And so up to 50% of sepsis survivors suffer from long-term physical and psychological effects. And from all these facts, we could know that sepsis is a really severe healthcare issue with so many of us involved. And for children, it's even worse, as sepsis disproportionately affects them, as you can see from the fact sheet that 40% of the sepsis cases are children under 5 years old. So pediatric sepsis definitely worth our additional attention. Then let's talk about the second focus, multiple organ dysfunction syndrome, short as MODS. MODS is defined as 2 or more concurrent organ system dysfunctions. MODS is highly likely to be developed from sepsis in pediatric patients, with even increased morbidity and mortality compared to a regular sepsis case. And we use the definition of organ dysfunction made in the International Pediatric Sepsis Consensus Conference in 2005, which includes 6 different organ systems. And patient who exhibits MODS at sepsis onset is much less likely to recover through treatment, and those who survive the MODS might still suffer from lifelong consequences to themselves as well as their families. So for those who are already in MODS when acquiring sepsis, it is important to investigate their chances to recover to a mild state with 0 or single organ dysfunction. And this is also the main motivation behind our study, that if we could predict who's likely to recover, we could provide the clinicians the opportunity to take extra care and enable timely interventions for those who may otherwise not be likely to recover. And we employed advanced machine learning models for this prediction task. While there's already a body of literature focused on the early recognition of sepsis onset, the prediction of MODS recovery in sepsis patients has never been attempted with machine learning. And also the standard of care at this moment is still rule-based. With this effort, we hope to develop the personalized prognostics for the pediatric sepsis patients with MODS. Our work is developed on the Swiss Pediatric Sepsis Study, short as SPSS. SPSS is a retrospective, national, multi-center cohort study investigating broad cultural proven sepsis in children younger than 17 years old. And this study includes 10 major pediatric hospitals in Switzerland. The SPSS database includes electronic health records at a daily level, which records the most abnormal measurements within every 24 hours. And these records present up to 6 days after blood culture sampling, or what we consider as the day of sepsis onset. And a recent systematic review of early prediction of sepsis onset shows that more than 85% of the studies only examined their models by cross-validation, limited to a single database, and the performances in other datasets were not verified, even though the models performed very well in their own settings. While the external validation is crucial for assessing the model's generalizability. So in this study, we managed to access to another pediatric sepsis patient database from the Ann and Robert H. Lurie Children's Hospital of Chicago, short as LCHC, for the purpose of external validation. Then let's give a proper definition of mouse recovery. We formulate this as a binary classification problem that we predict the chance of recovery from mouse in a week, using only the data from the day of sepsis onset. And here are a few example patients. We use blue arrow to indicate a patient in mouse state, and red arrow to indicate a patient not in mouse state. Day 0 is the day of sepsis onset, and we have the data until day 6, at which we predict if the patient will be recovered or not. The first example is a recovery example, as we could see that for the first 3 days, the patient was in mouse state and recovered to a mouse-free state in the last 3 days until day 6. The next example is a non-recovery example, and we can see that the patient started with mouse and got better for a few days, but eventually transited into mouse state again. And also, if the patient deceased before day 6, we also consider it is a non-recovery example. The last example was not suffering from mouse until transition into mouse happened on day 3, but we excluded this one as we only consider patients exhibit mouse on the day of sepsis onset. After we filtered out those invalid patients, we have 138 non-recovery and 118 recovery samples in SPS's dataset. And this translates to a positive class prevalence of 46.1%. And in LCHC, the external validation dataset, we have 210 non-recovery and 181 recovery samples. And it also has a very similar positive class prevalence of 46.3% and also a cohort size in the same order of magnitude. Then we selected 44 clinical variables for the prediction with the help from the clinicians, and these variables include vital signs, laboratory test results, clinical scores, chronic disorder information, and demographics. And these variables were only collected on the day of sepsis onset without any risk of future information leakage. We implemented and compared several machine learning models for the prediction task, including logistic regression, support vector machines, random forests, multi-layer perceptrons, and light gradient boosting machines. We also built a clinical baseline model based on the decision tree with the second pediatric logistic organ dysfunction score. And this score has been shown to be able to predict mortality on organ dysfunction in large pediatric databases, and also it remains the best validated criteria so far. And this baseline model aims to mimic clinicians' decisions in the real practice. We adopted a nested cross-validation scheme where we split the data into training, validation, and test set. And we repeat this for 10 independent rounds. The training and validation sets are usually used for hyperparameter optimization, and we report the performance on the test set only. Here on the right-hand side, you can see the performance on the SPSS cohort, where we use different colors to indicate different models. And the evaluation metrics, we use the AU-ROC and AU-PRC, area on the ROC curve and area on the precision recall curve. As you can see, all 5 machine learning models achieved comparable results, and they all outperformed the baseline model by a large margin. And random forest model is the winner of these 5, with an AU-ROC of 79.1% and AU-PRC of 73.6%. Therefore, we choose it as the model for external validation. And also, it is worth mentioning that although random forest models usually perform well in various tasks, they tend to be highly nonlinear and often not at all transferable. So it is particularly important to do external validation. And here we show the external validation performance. For the completeness of the study, we developed a random forest model on both centers and validated them on the other. And here are 2 plots showing the performance on the 2 centers. And the red curve with uncertainty bands are from the tenfold internal cross-validation, and the blue curves are the performance from the model that trained on the other database. And we can see that the prediction is successful in both directions, as the AU-ROC from both datasets on both internal and external validation are over 75%. And these models also have the AUPRC over 70%, with a positive class prevalence around 46%. And we can also look at the high recall regions, where it's usually of more clinical interest, since most of the events can be captured. For example, when the recall is at 80%, this means 4 out of 5 recovery events were correctly predicted. And the models still have 60% precision scores. And this means that for every 5 positive predictions the models made, 3 of them are true. And this high performance of the model on the unseen patient data from another clinical institution proves that the machine learning models we developed in this study can generalize well in terms of this mouse recovery prediction task. Then we further analysis if the random forest model could predict the mouse recovery earlier than 6 days from the sepsis onset. And here we show the relative AUPRC of the predictions from different days of sepsis onset. And the relative AUPRC is the absolute AUPRC divided by the positive class prevalence. And using this metric, we can have a rather fair comparison over different time points. And we developed this random forest model on SPSS database and evaluated them on both databases. The relative AUPRC on the SPSS cohort goes down by increasing the horizon. For the external validation LCHC, the relative AUPRC increases in the first 3 days and starts to drop afterwards. On day 6, which is our main focus, both internal and external validation achieve very similar performance, and this is as expected. As for a shorter horizon, we should have a better performance. But for the temporal limitation of our datasets, the prediction could only be made in the first week of sepsis onset. For longer horizons, such as 2 or 3 weeks, we would expect lower prediction performance. However, sepsis in children is a highly dynamic disease with progression or recovery often seen within the first few days after admission, and the persistence of MARS on the first week is associated with high morbidity and mortality. And also, we would like to have a model with both high performance and high generalizability. So we chose to focus on the day 6 for the MARS recovery prediction in this study. And another thing we desire is the high interpretability of the model, as the decision making in clinical practice is a high-stake process that comes with the potential impact on the survival of the patients. So here we use shape values to explain the risk factors discovered by the model. Here we use the B-swarm plots to visualize how the top 10 features impact the model's outputs. And here in the plots, each instance is represented by a single dot, and the red dot indicates higher value and the blue dots indicate lower value. And if the dot is closer to the right side of the x-axis, the feature is more likely to push the model to give positive prediction and vice versa. So the top 10 features discovered by the models are the lowest oxygen saturation, the highest lactate, the lowest systolic blood pressure, the highest inspired oxygen fraction, the lowest mean arterial blood pressure, the highest arterial packed CO2, the highest heart rate, and the cardiovascular failure indicator, respiratory failure indicator, and chronic lung disorder indicator. And for example, if the patients have higher oxygen saturation, and the model will tend to give positive prediction, as you can see in the first row of the plot. And this means the patient will recover on day 6. And if the patient has higher lactate values, as you can see on the second row of the plot, and usually heightened lactate indicates organ damage, so the model will assign lower chances on the patient's recovery. And what's interesting is that we found the 2 organ systems, namely the cardiovascular and respiratory, are highly critical in the early prediction of MARS recovery, as most of the top 10 features are associated with these 2 systems. With this being found, we should pay more attention when taking care of the MARS patients with cardiovascular or respiratory failure, rather than treating them equally to patients with other types of organ system failure. Then we can further look closely on 2 patient examples of how the model made the decisions, a recovery and a non-recovery example. And the recovery example had a relatively high heart rate and lactate level, but did not have respiratory or cardiovascular failure, and the oxygen saturation and blood pressure were at a relatively normal value, so he or she eventually recovered. The non-recovery example had a similar oxygen saturation, lactate, and heart rate level, but due to a high inspired oxygen fraction, and this usually means mechanical ventilation was applied, and also low blood pressure, and also cardiovascular failure, he or she got a very low score and didn't recover from mouse. And these two examples further help us to better understand the model's interpretability. Then I would like to summarize our work in this slide. So we have developed a machine learning framework for prediction of mouse recovery in pediatric sepsis patients in 1 week in advance. And we conducted comprehensive experiments to demonstrate the proposed model can not only predict mouse recovery with high accuracy, but also can be transferable to unseen data from different clinical sites, and even in an intercontinental setup. And we also showed that the model is highly interpretable, and this means the decisions it made make clinical sense, and which makes the model more understandable to the clinicians and also can provide more insights. And finally, we believe the proposed model has certain clinical utility, as it could assist the clinicians in identifying patients with high risk for complicated clinical course in advance, and thus provide better patient assessment and triage. And with all this brings me to the end of my presentation. Thank you for your attention.